The topic of today's discussion is to talk about the current status of CLL treatment globally. We have in the last decade or so seen a paradigm shift in the management of CLLs, especially with the understanding of the biology of the disease, and also the understanding that CLL is not one entity, but maybe 2 or 3 different entities having different progression rates and different responses to treatment. It's a well-defined lymphoid, and as part of my talk, I would confine myself in the first-line treatment because, in the interest of time, it would be rather difficult to go in for the relapsed refractory setting. But it's a well-defined lymphoid neoplasm with very heterogeneous biological clinical behavior. And as Dr. Verma had alluded to, the pathogenesis of the disease is influenced by genetic susceptibility does exist. There are immunogenetic factors which drive the disease, several genomic alterations that exist, and the epigenetic mechanisms, including epigenomic reprogramming, that goes into the pathogenesis of the disease. The interaction between the tumor cells and the microenvironment, and also the systematic clonal evolution from early steps in a multiple B lymphocytosis to progression and transformation to an aggressive form, including a diffuse large B-cell lymphoma, as we see in Richter's transformation. So we know that it's not always a single entity. It is an unstable disease, mostly indolent, warranting at times a sustained therapy to keep it under check. So have these understanding of the pathogenesis really translated to a bench to bedside for therapeutic benefit? And we do currently only look at certain parameters presently, which are considered most of the time to decide therapy. And most of the time, these include the cytogenetic status, the IGHV mutation status, the TP53 mutation status, and sometimes some of the other entities, such as the Notch1 status. And we do understand that a lot of the disease is dependent upon the BCL2 stimulation and much of the downstream pathways, which we try to perturb as part of a treatment, and which has actually translated into significant benefits in terms of controlling the disease. So let's go to what is the role of chemoimmunotherapy. Chemotherapy has always been there for CLL. It does control the disease to a certain extent, but we do understand that that control is temporary. And then the advent of the use of monoclonal antibodies improved the outcomes of these patients. Currently, we do understand from the historical perspective, when we look at CLL, when we talk about the chemotherapy and the introduction of chemoimmunotherapy, there is a difference in terms of the kind of drugs that we use, and we do understand today that if at all we need to use chemotherapy, they include those subset of patients who have a certain specific profile in terms of an IGHV mutation status, being P53 negative, and also sometimes there is an influence of the cytogenetic profile. For example, 30q does better than probably the 11q abnormalities. So, and when we look at this as a graph, in this graph, we do understand that those patients who are classically the IGHV mutated, who are negative for any P53 mutations, and they are the people who benefit maximum to the use of chemoimmunotherapy. And when we look at the data from the mature data from the MD Anderson group, who looked at almost 300 odd patients, it was clearly demonstrated that for those patients who were IGHV mutated, they were the people who benefited with chemoimmunotherapy. And if you looked at the long-term data, it was understood that if there was no event that were happening beyond 8 years of age, then they had something like a functional cure. And for those patients who did achieve a measurable residual disease negative status, they were the people who went on to have a long-term functional cure. And these higher proportion of patients who achieved their MRD negative status were concentrated in the pool of patients who were IGHV mutated. So thereby saying that there can be a benefit for chemoimmunotherapy in a subset of patients with this profile that we come across. But FCR is never something that can be used that easily. And this was the CLL-10 study, which compared the FCR with bendamustine, which clearly demonstrated a benefit for progression-free survival still for the FCR regimen, but it did not offer that kind of a benefit in the older patients because of the sheer toxicity that the FCR regimen induced in such patients, and that sort of negated the benefits of the FCR regimen in these patients. But having said that, in this randomized study, there was a sense of there was a benefit in terms of the patients achieving a better MRD negative status for the FCR regimen as compared to the BR regimen. There was a benefit towards a better progression-free survival in these patients, but again, the caution was to use it very carefully in the elderly patients. And currently, we do not generally recommend using the FCR regimen for patients above the age of 60. But then you need to look at the fitness quotient of such patients to deliver these kind of therapy. So is it possible to do away with chemotherapy? We do understand that the efficacy of the BTK inhibition and also the pathway through the downstream pathways of the BCR and the BCL2 has yielded benefits, and this was mainly from the phase 2 and the studies in relapsed refractory CLL patients where they used BTK inhibition in the form of Ibrutinib, which is a BTK inhibitor, and used it against the standard of care, which was compared it to the standard of care, which is Chlorambucil. And clearly, there was a benefit in terms of both the overall survival and the progression-free survival and overall survival of these patients. And when you looked at the mature data at 16 months, there was clearly a benefit, an incredibly superior benefit for Ibrutinib, with a progression-free survival of close to 70% in these patients as compared to the chemotherapy arm. Similarly, the RESONATE study was one that clearly put Ibrutinib on the map as far as the first frontline therapy for CLL was concerned. And more importantly, what it demonstrated that irrespective of the risk groups that were involved, irrespective of the IGHV mutation status, irrespective of the TP53 mutation status, there was a benefit for use of Ibrutinib, and it sort of overcame the negative impact of these profiles in CLL. Similarly, the E1912 updated progression-free survival on the long-term follow-up clearly demonstrated also that when using it with the standard of care, which was FCR in patients in CLL, there was again a benefit for the combination of Ibrutinib with rituximab in these patients. Again, for those patients who were unmutated, there was definitely a vastly better outcome for patients who received Ibrutinib as against the FCR regimen, thereby saying that the use of FCR or chemoimmunotherapy is probably only confined to those patients who are IGHV mutated and who do not have any of the TP53 mutation that is seen. The updated analysis, the progression-free survival improved with Ibrutinib also when compared with the other standard of arm, which was the 41202 study, which compared Ibrutinib with bendamustine and also the third arm, which used Ibrutinib as a single agent, clearly demonstrating a superiority of Ibrutinib combination rituximab. And what this study also brought about was that rituximab perhaps did not offer too much of a added benefit when using ibrutinib when ibrutinib was in the regimen, and demonstrated that perhaps we could, when you're using ibrutinib, perhaps rituximab did not have too much to contribute to the outcomes in these patients. And similarly, when we looked at the adverse profile patients, which is the deletion 17p and 11q abnormality, again, ibrutinib was way ahead in terms of its outcome as compared to the standard chemotherapy arm. And that was again true for the IGHV mutation status. So the next drug which is on the block, which is acalabrutinib, which will be discussed in more detail in the subsequent talks by our esteemed international speakers, this is just a novel irreversible second-generation BTK inhibitor that was rationally designed to be more potent and selective than ibrutinib. And it was developed as a selective BTK inhibitor, and the goal of achieving similar therapeutic outcomes in patients with CLL without off-target effects, which was quite typically causing the side effects that were associated with ibrutinib. And there were several preclinical studies that had demonstrated the efficacy of acalabrutinib as a BTK inhibitor. And I will just allude to one of the studies because I'm discussing this talk as basically focusing on frontline therapy. This was the treatment-naive CLL patients where acalabrutinib was used with or without obinutuzumab versus chlorambucil and obinutuzumab for treatment of naive CLL patients. And what again it clearly showed, as we know with all the BTK inhibitor graphs, which we are familiar with now with ibrutinib, there was clearly a superiority over the standard chemotherapy arm. And there was probably, as against the study wherein it compared, where ibrutinib was compared with bendamustine rituximab versus ibrutinib alone, here there perhaps obinutuzumab did contribute a little bit more to the regimen as against acalabrutinib, but it was not statistically significant. So going beyond BTK inhibition for durable responses is the next step that has been looked into in frontline setting. And this was explored with the use of direct BCL2 inhibition using venetoclax. And this was a study which was derived from other conclusions of various other use of venetoclax in second-line relapsed chronic lymphatic leukemia, such as the Murano study, which demonstrated the benefits of venetoclax when used in this setting for patients who had failed first-line therapy. And one of the things that had come out of this particular study was the ability for venetoclax to induce measurable residual disease negative status over a period of time. And also the understanding that venetoclax perhaps needs to be taken as a continuous therapy. So the CLL14 study clearly looked at a combination of obinutuzumab plus venetoclax along with versus chlorambucil. And again, there was a clear benefit for the addition of venetoclax to the regimen, with almost a 25% improvement in the progression-free survival over a period of time. And what was important was there was particularly no. The benefits was across all risk profile patients for venetoclax, and therefore. As is true with ibrutinib, the benefits of using venetoclax in these patients was clear to see, and again demonstrating that perhaps chemoimmunotherapy is probably not currently one of the more favored modes of treatment for CLL in frontline setting, except in very, very specific situations. And as I said, the most important thing that I would consider in this study, which was a study conducted from the MD Anderson group, which looked at combining Ibrutinib with venetoclax as a frontline treatment in high-risk patients of CLL. And this was including at least having a deletion 17p, p53 mutation, or unmutated IGHV state. And the treatment plan was to use Ibrutinib three as a lead-in cycles of 3 cycles, followed by introduction of venetoclax after the 3rd cycle. And what we see over here is that while Ibrutinib can control the disease, there is, with the addition of venetoclax, there is a progressive improvement in clearance of the disease from the bone marrow in the form of achieving MRD negative status as we go along. And this was what was replicated from what we saw in the second-line setting for CLL in relapsed CLL patients where venetoclax was used. So there was a clear demonstration of achievement of MRD negative status, which was something that one does not see often with the use of Ibrutinib. So the combination made sense, and this was one of the more relevant studies which came out for the combination for Ibrutinib plus venetoclax. So currently, when you talk about frontline CLL treatment approaches, we generally look for those patients who are suitable for systemic therapy, look at their mutation status at the beginning, and if yes, the option of using a BTK inhibitor with or without rituximab is reasonable, as was the use of combination of obinutuzumab, which I did not allude to. The Illuminate study demonstrated a benefit for the use of obinutuzumab in these patients in terms of a marginally better progression survival in these patients. The CLL14 study, again, demonstrated a benefit for this subset of patients. And of course, the Elevate study in TN clearly, again, showed a benefit for acalabrutinib in combination with obinutuzumab. So again, it is important to look at choice of treatment based on the cytogenetic profiling of these patients. And increasingly, as we go along, we are more inclined towards having a chemotherapy-free kind of a regimen for such patients. But the only drawback of this treatment is that it is a sort of continuous therapy in these patients. I think I have missed out on a few slides, but I will just allude to one of the interpretations of a continuous use of venetoclax, and because the protocol demanded that the use of venetoclax as per plan was only given for 2 years, but it was noted that those patients who had an adverse profile tend to have increasing relapses after the suspension of venetoclax after 2 years, thereby giving an indication that perhaps in the adverse risk profile patients, we may not be able to get away from stopping a drug such venetoclax, even though we might have achieved an MRD negative status in these patients. So we look at the treatment algorithm for newly diagnosed CLL currently. You have a newly diagnosed patient of CLL. If they are without a deletion 70p degree mutation, you do an IGHV mutation status. And if they are mutated, fit patients less than 65, the option of using a chemoimmunotherapy does exist, but increasingly the inclination is towards going towards a chemo-free kind of a protocol, which also includes the use of combination of Ibrutinib and venetoclax. But if they are IGHV mutated, it is always use of Ibrutinib, a BTK inhibitor, with or without a BCL2 inhibitor such as venetoclax, and with the option of using a monoclonal antibody, which could be either rituximab or obinutuzumab.